I'm Steve Moore. I'm the Area Team Director for Devon, Cornwall and Isles of Scilly, part of NHS England. It's great today to see so many people from primary care here helping us to think through what the future might be. When we first thought about having this event, probably some 3 or 4 months ago now, the real intention was to start to have quite a provocative discussion actually about how primary care needs to change in the medium term. What's clear, whether you look at the workforce, whether you look at the demands on the system, is primary care can't continue to deliver the same level of service in the way that it always has as we move through the next few years. So actually we need to have a debate about what primary care ought to look like. In effect, an open-minded discussion about what is the point of primary care in the 21st century. And I'm hoping that today, with colleagues from Health Education England, with our research people, with secondary care, that we can start a much deeper set of conversations about the future of primary care, what it will look like, and how it's going to deliver for our local population.
So we're all very good, I think, at articulating a care model, but the real devil is in the detail about the business model. So I'm hoping, I know I haven't said anything new to you, I hope some of it resonates, and I hope from a secondary care perspective it feels more empathetic to the scale of the challenge that we're all facing. And so from what I've picked up, it's less about what primary care needs to change, it's much more about what we all need to change to meet what we know is the case for change. So this isn't really about primary care, this is about what we all need to change. So secondary care was very empathetic, I think, and very understanding about the pressures and the workload.
The patients who get involved in research get better care. It's as simple as that. They are provided with closer monitoring, and it is beneficial to them in terms of their clinical conditions.
Understand where leadership sits. It's about dispersive leadership, not hierarchical leadership.
Local research for local needs.
So again, we need to look at how we develop our future workforce to meet the needs of the future. It's a really important thing that we need to hold on to, because that is, if you like, the jewel in our crown. It's about how we can develop services around a registered population. We need to make fast, responsive access to care. This is about trying to recognise that where we're at the moment needs a systematic change.
What does this expectation mean about the GP role in coordination of care, and what's the 7-day working that keeps getting sort of flagged around and in a moderately incomplete way in terms of actually working out how, but provocative, I suspect, about trying to get myself in the right position here in NHS England alongside the CCGs, about facilitating that without investing in the energy of trying to persuade practices of the changes that they need to make, because my experience is that nearly always encounters quite a significant sort of pushback in terms of antibodies that I will excite. And so the message I'm trying to give here is about one of, if there are issues facing yourselves as independent contractors about how you want to change the organisation of your business, then let that get discussed. I know it's challenging. I know what some of those sensitivities are and how they vary between places. But I also know that what I'm hearing from primary care is a set of pressures that people are saying, really not sure that I can keep going like this for another decade, or even another shorter period of time than that, is actually usually what people say. And so what am I going to do? Am I going to listen to that? And I think the answer must be yes. And if that answer involves you wanting to talk about how the provider landscape is organised and how practices work together, then, and how I use my contractual position to help foster that, let that discussion happen.
We're here really because somebody in NHS England wrote an interesting document called The Call to Action, which is the latest iteration, I think, in a fairly common area and a theme that we hear over and over again, which has had different iterations down the years. And it basically says there's no more money. We are going to have to respond to a changing demographic and increasing numbers of patients with long-term conditions and complexity of patients that are coming through the doors, and somehow we're going to have to cope with that. And on top of that, we're going to have to deal with an increasing demand for better services, for a better experience for patients, and they're not always the same thing. And I hope that we're all fairly agreed in our desire for better outcomes.
You're not doing the two things that we need: healthier people and fewer of them. I like this, Office of Health Education. Economics, sorry, I like it. Now the pink line is women, blue line men. As you can see, women do wrong than men. The reason for that is simple. Men lead blameless lives and I'll take down
As I'm in the hospital and we've had ED breaches and follow-up backlog and clinical incidents, you do just think, how do you get enough headroom, space to think about what we could do differently? And it's very hard, isn't it? And if we move on, some of the things that make it quite challenging, I think, is, well, what is our collective endeavour? There is undoubtedly, and I don't think anybody would be sat in the room thinking that there isn't a case for some radical change. If we don't start doing something differently across the whole patch, it's going to go pop, I think, one way or another. So, secondary
CCGs up with NHS England so that they've got an overview of everything.
We can sort things out between primary and secondary care, but as long as the kids are getting fatter, there's more fat kids coming from them. So we need to have much more activity in the prevention.
But some of the demand,
Otherwise, some of the demand
is
will work.
politically driven. We've had successions of administrations that have been making NHS promises with the statements, this is what you can have from the NHS, aren't we nice, please vote for us. And they've been writing cheques on the NHS which the NHS can't cash. And that's where demand comes. You can have what you want, whenever you want it, on a Sunday afternoon.
So why do I need to know? Or why does Anne need to know? Of course we need to know, but who else needs to know before that? Because we're sort of the end point. It should be working more dynamically than that, shouldn't it? We should be able to raise things and say, we're not reporting that person because his outcomes or her outcomes, surgical site infections or something is always a whole lot higher, or my patients always get readmitted. How do we flag those things up together between us? I think it's a serious issue.
One thing, just because I did do it, I was really interested in that bit of the discussion. And I think there is, I said it just in the presentation, you can change a few words, but there's almost a mirror view. So if you know that there is somebody who's not very good in the orthopaedic team, I bet you I could go to each team and say, which of the GPs might you have concerns about? And they'd tell me. They'd tell me which ones they don't feel do the referrals right or don't.
But that should be looked at.
Exactly, which is exactly the point. But what I think we need to try and do is think about how we create a climate where it has a different sense. It's not this push-pull, because when I've seen debates happening, where we've had, GP colleagues with our medical staff, they've very rightly raised the issues about some of the consultant issues. All that does is prompt a consultant response to say, well, we might not be doing the discharge letters so well, but you should see the state of some of the referrals we get. But you end up, the whole system, it feels a bit divisive to have a dialogue which is not helping achieve a better outcome. It's a bit of a ping pong.
So I think we'll look back on today and with a very positive view in a couple of years' time. We've seen a day when folk from across the whole patch, Devon and Cornwall, been representation from some key organisations, some people with clear strategic vision for change and how things might develop. I think it's enormously positive. We've had some very positive individual suggestions in the group that I was part of, some important observations around delivering strategic revisions to care for the elderly and care homes. I think if we can achieve some of what's been flagged up today over the next 6 months or a year under LAT leadership in conjunction with CCGs, we'll have done a good job.
So I've really enjoyed today. I think it's been long overdue in many ways that we were able to get together with primary care and hear a lot of different speakers. I was really struck that everybody, whatever their perspective, felt that there was a different way, a need for more radical change. Not restructuring, but a bit more focus about how we're going to address what we all would recognise as a lot of pressure and workload in the system. So I was really heartened that actually something that we feel in secondary care is probably mirrored back in primary care. So I'm really looking forward to how we might take this forward with renewed energy and focus and a sense of ambition. And I thought the day was fabulous. I hope we have another one soon and perhaps have some more secondary care clinicians in with the debate next time.
Today's been a good day. I've really enjoyed today. I think we've heard an awful lot from an awful lot of inspirational speakers, but much more importantly, we've heard from people who are working here in Devon, Cornwall and the Isle of Scilly, understanding some of the big issues, some of the challenges that face us all. And I think what I've taken away from us, from this sort of discussion today, is actually we need to make sure from an NHS England perspective that we are allowing the area teams and the CCGs to get on and do it, to really be able to make the difference, to put the patient at the centre of the journey, to make sure that the patient's view is being heard, and to make sure that actually the collaboration between primary and secondary care, between medical services and dental, pharmacy or optometry services, and working with the voluntary sector, the clinical community, making sure that they can actually sort of pull together, align the vision, and so we can actually deliver something which is sustainable and deliverable for the future.
I think we've had a really, really interesting day today. We've had a lot of people from different parts of the health service, massive representation from colleagues working in primary care, but also some of the other organisations, the hospitals, the academic health science networks, the education and training boards. I think what I've taken away from it is that we have to change and we need a paradigm shift now. And I think the message is it's not about waiting for people in national offices to tell us what they think we ought to do. We need to own that challenge, and I think it's about building relationships so that we can work collaboratively together, come up with some new ideas, be brave in challenging each other and be brave in actually recognising that some of us may be doing things very differently in the future. Some of us may not even be doing some of the same things in the future. And I think we've talked a lot about the medical contribution, the need to change the pattern of the workforce, how nurses can make a contribution there and other members of the healthcare workforce. So I found today very exciting, and I think looking forward now to working with my other colleagues across the local health system to make that change real.
Well, look, we've had a great day. I guess what comes out of it for me is this. The NHS was born on the 5th of July 1948, which is actually 2 years after I was born. Can't believe it, but it's true. And if you think about it, think about other businesses and other organisations that have been around for that length of time. The banks, they've changed enormously. We now get our money out of the ATM or online. If you have a look at the petrol stations, they make money now selling sandwiches and flowers. It's not about petrol. Almost everything has changed, but the model of healthcare that we've got is still, you don't feel well, you go to the GP, and then if he doesn't know, he sends you to the hospital and you all go around in a circle. Now, either that is a model that is so good that we need to protect and preserve it and maybe pay more taxes to do so, or maybe we say, do you know what, it stood the test of time, it was really great, but now it's time to move on. And move on to what? Well, I think what we saw today were a lot of people who were really interested in looking at what they could do differently and how the NHS can move on. It's a very difficult time for the health service, saving £20 billion over the 5 years up to 2015. It's a big ask. After that, it's going to get even tougher. So I think, change is not an option anymore. It's just a question of what. And here's my tip for change. It's really very easy. All you have to remember is this. People love change if they think they're in charge. And what we did today was gather people's ideas and put them in charge. So let's see what happens.
I think the great positive about today has been the recognition for everybody involved that there is a real need to radically change the way in which we not only deliver primary care, but how we radically change the way primary care is delivered within the whole system. And it's been great to see the energy, the creativity and positivity today from a wide range of contributors. And I'm really confident that moving forward that there is a will to harness the collective endeavour from the system.
It's great to see so many people here today, particularly from primary care out there, our jobbing GPs and nurses. When we first thought about doing this workshop, our intention was really to start to provoke a discussion about the fact that primary care can't continue to do the work in the way that it currently does it. It'll simply be overwhelmed by too much demand, too few clinicians to cover it. So for me today has been about starting a discussion, an open-minded discussion actually, about how primary care ought to change in the medium term. What kind of primary care we're looking for, how it's going to be delivered, how we're going to continue to deliver safe services to people with multiple long-term conditions, as well as those people who want quick, easy access when they need it. So I'm looking forward to this being the start actually of a much longer conversation about how we're going to move this forward over the next 5 to 10 years and being part of the national debate about where primary goes in the future.